Hello, I'm Joe Ibrahim, and today I want to talk to you about... Excuse me? Sorry, my old friend Mr. Jones says today he would like to talk about something that's got him very upset. Apparently, it was a question he was asked by a doctor like me. A question he considers was very inappropriate. Okay, why don't we look into this in a bit more detail? As you can probably tell by now, Mr. Jones has gotten himself into a royal sting. So angry, in fact, that he wants me to speak on his behalf. Okay, so where were we? Ah yes, that's right, the inappropriate question. I was going to find out what it was, but first we need to put ourselves in Mr. Jones's shoes. Mr. Jones and his wife Rose are in their late 70s and they live in a quaint little house in the suburbs. They're both pretty healthy apart from a few medical ailments. They've been doing just fine with a bit of help from the council and the family. Mr. Jones had some issues with his fitness for driving, with the doctors thinking about taking away his licence. Oh, okay. Anyway, recently though, Rose has been having some issues with her hip. Sorry again. Apparently, minor issues with arthritis in her hip that have been making it difficult for her to walk. Well, I consider that a bit more major. But anyway, they went to see their doctor and they were told that Rose could do with an operation to replace her hip. An operation? Really? After all, things weren't too bad. It was just a bit of pain on walking. Should they really risk an operation at this age? But the surgeon had reassured them, yes, there's always a risk, but don't worry, it's a fairly common operation nowadays, and keeping her up and about is important. Given her history, she's likely to be just fine. It sounded like a fairly routine kind of thing. This morning, Mr. Jones had been really good. He got everything prepared. Her favourite nightie, her favourite muffins, reading glasses, her favourite book. They made it into the hospital and they loved the staff. Finally, Rose came back from the operation. Over the next couple of days, the medical staff looked after Rose really well. They got her up and walking, and soon she was home again. They were both so relieved. Everything had gone so well. About a week later, out of the blue, Rose suddenly got short of breath. And they had to go back to the hospital. A very mild pneumonia, they called it. Nothing to worry about, they said. They started Rose on some antibiotics. They told me she would be fine. But then... that doctor came in. That young doctor came in. At first he was great. He explained about the steps being taken to treat Rose. But right at the end, just as they'd started to relax, the doctor did something terrible. He said, "Now we're treating you with all the right things, and we expect you'll be fine. But given your general health is not great because of the diabetes, high blood pressure, and your kidneys not working so well, I'm just letting you know that if by chance your heart was to stop, we wouldn't think it would be a good idea to try to resuscitate you. We call this a not for resuscitation order, and I wanted to fill one out for you. Is that okay?" What kind of question is that? How dare he? We've come back into this hospital trusting everyone. They cared so well for Rose before. The bone doctor wasn't worried about any of those problems Rose has. So what's changed now? Just look at them. They don't care. We're being told they won't look after Rose if something goes wrong. Why would he say that? Of course we want everything done. Of course we want them to bring her back if her heart stopped. Are we missing something? Oh, so I see now what Mr. Jones is saying. The inappropriate question that has him shocked. It's about resuscitation. I can see there's a real disconnect here. Let's see what we can do to clear things up. Well, Mr. Jones, I can see why you were confused because an NFR order is a very specific hypothetical, and it seems a long way from where you and Rose are now. NFR stands for Not for Resuscitation, but these orders can go by other names like No CPR or DNR, Do Not Resuscitate orders. Their purpose is to try to reduce the use of resuscitation measures when they are unlikely to be successful and actually might do more harm than good. Okay, fine. So that sounds confusing. I know what you're saying. How can trying to save someone's life with CPR do them harm? Well, part of the reason people don't like talking about these things is because the movies have let everyone down. Yes, the movies. But unfortunately, in real life, not everyone who has CPR actually survives. Don't get me wrong. CPR is very important and it does save lives. But as we get older and develop medical issues, the chance of success gets lower and lower. And it's also far trickier than it looks on TV. It takes significant physical force on someone's body to get someone's heart going again. And we also use breathing tubes and other invasive things to help us. If we do manage to get things going again, people don't just get up and walk away. There's a recovery process. And sometimes people who have CPR don't do as well as we would like, and they can be left with brain damage as a result. Whilst we should always do CPR when there's a good chance of helping, we don't want to put someone through unnecessary harm when there's little or no chance of benefit. So I agree, Mr. Jones, it is a confronting question and a confusing one too. And sure, it could have been brought up in a better way, but the reason why it was brought up is that these decisions are not always simple, and it's too late to have a discussion if an emergency actually happens. The aim is to get everyone's thoughts out in the open ahead of time so that things can be discussed. So it's worthwhile thinking about how decisions about resuscitation are actually made. Well, there isn't really one answer to this because it depends on a lot of things. But there are some reflections that can help you understand things a bit better. Outside of the hospital, in the general community, say on the street or at the supermarket, when an emergency happens, the default position is to always do CPR and to try and get the person to a hospital. In a hospital, well, the situation's different because we have the opportunity to think about things before they actually happen. As a general rule, when there are no orders in place, the staff will always commence CPR until a definitive decision can be made. If, however, a not for CPR order is in place and it applies to the current situation, resuscitation is not attempted. A discussion about CPR is an opportunity for people involved with the patient's care to discuss the patient's values, beliefs and concerns about the resuscitation process, as well as the individual patient's situation ahead of time. The medical team can talk about the patient's care and the likely outcomes of resuscitation should it ever be needed. If the patient is unable to speak or communicate their views, then their substitute decision maker is asked what they think the patient's wishes would be. Some patients may have already expressed their wishes in the form of an advanced care directive. If the patient or the medical team do not feel that resuscitation would be the best course of action, they can then record the decision as an official, not for CPR order, so everyone knows what's been decided. Getting these views out early also means that any disagreements between the patient and the medical staff can be discussed, and other opinions can be considered if needed. It's important to note that decisions about resuscitation have nothing to do with other medical treatments, and patients who have not for CPR orders still receive their other medical treatments as usual. So there you have it, a little bit of an insight into not for CPR discussions. It's not always easy to do, but it's useful to discuss everyone's views ahead of time. If you have any questions about resuscitation or your specific resuscitation plan, I encourage you to discuss this with your doctor. I'm Joseph Ibrahim. Thanks for watching.